Hey everybody, my name is Katie Cook, and today I'm going to be talking to you about anticoagulation. This is a very high-level overview and really kind of represents the down and dirty dosing about how to use these different anticoagulants, but I encourage you to look at the guidelines for a lot of these therapies, which I will give you references for at the end. So the objectives are going to be to identify the appropriate indications for anticoagulation to include treatment and prophylaxis, to discuss dosing and monitoring for heparin and low molecular weight heparin, which is also Lovenox or enoxaparin, talk about the direct oral anticoagulants or DOAX, Warfarin, and then assess when and how to bridge correctly from one anticoagulant to another, and to list available reversal strategies, just briefly for select anticoagulants.
Some of the common indications that we see with anticoagulation, one being the venous thromboembolism prophylaxis. So a lot of patients who come into the hospital will either get put on Lovenox injections or sub-Q heparin 3 times a day. Other indications would be the VTE treatment, so if it's DVT or PE. We also see AFib, we see a new indication for valvular heart disease, and then some other indications that we won't go into as deeply today would be acute coronary syndromes and then post-surgical treatment as well.
For patients with atrial fibrillation, the CHA2DS2-VASc scoring tool is used to estimate patients' risk of having a thromboembolic event. This scoring tool takes into account 8 different characteristics that patients can have, and patients can score up to a maximum of 9 points. If patients have congestive heart failure, hypertension, diabetes, vascular disease, are female, and are between the ages of 65 and 74, they will receive 1 point for each characteristic. Now, if they've had a stroke or a TIA in the past, or are at least 75 years of age, then they'll receive 2 points for each of those characteristics. Of note, patients cannot receive points for both age categories. So for instance, an 80-year-old patient would receive 2 points for being at least 75 years of age and not 3 points. So for an example, an 80-year-old patient who has hypertension and diabetes would have a total of 4 points. Essentially, the higher the CHA2DS2-VASc score for the patients, the higher their risk is of having a thromboembolic event. When interpreting how to use this CHA2DS2-VASc scoring tool, if a patient has a score of 2 or greater for males, or a score of 3 or greater for females, the current AFib guidelines from 2019 recommend anticoagulation to lower the risk of a thromboembolic event. Now, when choosing a specific anticoagulant, direct oral anticoagulants, which will be discussed in more detail later on, are the preferred agents over vitamin K antagonists, such as Warfarin. The current AFib guidelines also recommend assessing the patient's bleeding risk using the HAS-BLED score, which is shown on the right. This score takes into account multiple different risk factors that can increase the risk of bleeding. Some of these risk factors are modifiable, such as concomitant drugs and alcohol, or a labile INR, but many of these risk factors are not modifiable. Patients can score up to a maximum of 9 points for this one as well, and the higher the score, the higher your risk is for bleeding. There is no recommendation for stopping anticoagulation if your HAS-BLED score is a specific number, but it does allow us to have a more holistic picture when deciding to anticoagulate a patient.
Okay, so first we have the intravenous anticoagulants. We have unfractionated heparin or heparin, which is kind of our run-of-the-mill heparin that we use for either subcutaneous or intravenous administration. We also have low molecular weight heparins, such as enoxaparin or Lovenox, which is our most common used low molecular weight heparin, and then dalteparin as well. We have a factor 10A inhibitor, fondaparinux, and then just for completeness sake, I included direct thrombin inhibitors, argatroban and bivalirudin, which you may see less frequently, obviously, in the outpatient setting for sure, and then less frequently in the hospital as well. So starting with unfractionated heparin, the mechanism of action is that it inhibits factor 10A. Its indications are numerous. We can use it for VTE prophylaxis, for treatment, for acute coronary syndromes, for AFib, and then we also use it in hemodialysis. It's contraindicated in patients that have a history of heparin-induced thrombocytopenia, or a lot of people will call this HIT. This is something that you should be acutely aware of, and we'll talk about as well. For severe thrombocytopenia, I think the number is kind of relative to maybe the trend that the patient is having with regards to their platelets, but in patients that have extremely low platelets, it should be cautioned in using any type of anticoagulation. And then, of course, patients with active bleeds should be very cautious in using. So for dosing, it can be administered subcutaneously, and really this is only for DVT or VTE prophylaxis. It's usually administered 5,000 units TID. And then we have intravenous or IV administration, which is for ACS or DVT-PE. And really, hopefully, you're in a place where you're able to consult pharmacy for this. This is something that we kind of take ownership of in the hospital setting. So if you're ever in a situation where you need this, and maybe it's at a different hospital, I would definitely touch base with pharmacy to see if they have a protocol for this. Most of the IV heparin administration in the hospital setting is protocolized, whether it be by nursing or by pharmacy. So I would definitely touch base with somebody because the dosing is very dependent on patient weight, on other factors, on the goal heparin levels, depending on what you're using it for. So we're evaluating all of that. So I encourage you to touch base with those people. Side effects, of course, for heparin would be bleeding, bruising, HIT, of course, and then you can see skin necrosis in rare cases. So low molecular weight heparin has a similar mechanism of action to unfractionated heparin, and its indications, again, are very similar for DVT prophylaxis, for VTE treatment, and for acute coronary syndromes as well, which is less commonly seen. We more often will see the IV heparin for the ACS patients. It's contraindicated again in patients with a history of HIT, except for fondaparinux, which can be used in those settings. Severe thrombocytopenia, active bleeding, and then hypersensitivity to pork products. This is kind of something that's an interesting fact and maybe something that you'll see in your practice. Heparin can be based with a pork product, and so if you have patients that have either intolerances or maybe religious preferences that they avoid pork products, this can be an area for conversation. So for low molecular weight dosing specific for enoxaparin or Lovenox, this is going to be the product that you will most often see. For DVT prophylaxis, we usually base this on creatinine clearance in the hospital, and pharmacy will be very involved in making sure that patients are getting the right doses. And we use a cutoff of a 30 for their creatinine clearance. So if it's better than that, they're going to get 40 a day. If it's less than 30, they're going to get 30 a day. We do have a protocol here at Cone specifically, although it may be different in different healthcare settings depending on where you practice. For patients that are obese or have a BMI of greater than 30, that we can use 0.5 milligrams per kilogram per day for their DVT or VTE prophylaxis dosing. So for treatment, for DVT or PE, we also use that same cutoff for creatinine clearance. So if their clearance is greater than 30, we'll use 1 milligram per kilogram Q12 hours, or you can use 1.5 milligrams per kilogram per day. These differences in these dosing depends on how big the patient is and how much has to be administered. As you may know, Lovenox comes in a very specific dose per syringe, and so sometimes we have to play around with these different types of dosings depending on the size of the patient. If their clearance is less than 30, then they're only going to be receiving 1 milligram per kilogram per day of the Lovenox for their treatment. Other dosing I just wanted to mention is available for ACS patients, as well as patients that are post-orthopedic surgery and for bridging specifically. Lovenox is a very common agent that we use for bridging, which we'll talk about in a little bit when you're starting somebody on Warfarin especially. And so there are other dosing regimens available for these indications, and I would encourage you to make sure that you look up those doses if you see this in your practice. So monitoring for low molecular weight heparin, specific for enoxaparin or Lovenox, again, which is the one you're going to see most often, you can actually monitor anti-10A, or what we call in the pharmacy world a heparin level. And usually this is drawn 4 hours after an enoxaparin dose. We usually prefer to draw it after 2 or 3 doses have been given. Obviously, this is more common in patients that are receiving treatment dose Lovenox. And in patients that have extremes of weight, so if they're really tiny or they're morbidly obese, if they're pregnant, or if they have severe renal impairment, then these 10A levels are more reasonable. Usually we don't do this in all patients receiving Lovenox for VTE treatment. But it's important to know that if you see any of these patients with these risk factors, that you can draw these 10A levels to evaluate whether or not they're in a therapeutic range. So other things you would be looking for would be a CBC, of course their renal function. We usually prefer heparin in patients with really severe renal dysfunction or end-stage renal disease, and then we're also looking for signs and symptoms of bleedings. Other side effects like bruising and bleeding, similar to heparin, we would recommend monitoring for as well. So this is just a summary slide with a lot of the more specific dosing. I won't go through all of this. I did include fondaparinux on this slide as well, although again, this is something that's not used quite as frequently as the unfractionated heparin and the enoxaparin. You'll see I've bolded for prophylaxis in Lovenox, 40 milligrams subcutaneous Q24. That's really kind of our workhorse in the hospital. That's what we use for almost all of our patients unless they have significant renal dysfunction. You'll also see that ACS has dosing for the enoxaparin and fondaparinux, which again is a little bit less common than seeing unfractionated heparin in those folks. And then for AFib, you'll see unfractionated heparin, which is used initially for those patients that come in that we may be either transitioning on or off of a DOAC or Warfarin and they need coverage immediately. We're using unfractionated heparin for those patients. You'll see in the dosing under unfractionated heparin, it's weight-based, although we make a lot of other clinical decisions about these patients, and these doses change quite a bit. We've got some different ranges in the pharmacy department that we use for dosing heparin and then adjusting based on their levels. So again, I recommend touching base with pharmacy if you have to use unfractionated heparin for any indication. A couple of just little clinical pearls. Low molecular weight heparin, we're going to talk about in a little bit. One of the ways that you reverse heparin is with protamine, and it is low molecular weight heparin or Lovenox is not fully reversed by protamine, and so I think that's just a little factoid to remember. And then, as I said previously, unfractionated heparin is really preferred over the low molecular weight heparin in patients with either acute or chronic renal failure. Although we do see it, it's really if you have somebody that has end-stage renal or an impressive AKI, then unfractionated heparin would be preferred. Oral anticoagulants. We're going to talk about each of these together. The first one, of course, is Warfarin or Coumadin, which is a vitamin K antagonist. We have a direct thrombin inhibitor, dabigatran, and then factor Xa inhibitors, including apixaban, edoxaban, and rivaroxaban. So first we're going to start with Warfarin or Coumadin. The mechanism of action is that it's a vitamin K reductase inhibitor, and it prevents activity of factors 2, 7, 9, and 10. And it's indicated for post-op DVT prophylaxis in some patients. That's kind of a newer indication, and I encourage you to look at that dosing if you do come across that. That's something that more orthopedic providers are using. VTE treatment, of course, AFib, so chronic use, and then valvular disease in patients with mechanical heart valves. It's contraindicated in pregnancy. It's also contraindicated in patients with a recent hemorrhagic stroke or active bleeding. People that have spinal catheters or acute aneurysms should probably also avoid warfarin. I'll say here that there's a lot of times when you may have a patient that's had some sort of spinal procedure or maybe had an epidural, and there's usually a lot of very specific guidelines about reinitiating or stopping anticoagulation in those patients. Also, people that have CNS or ophthalmic surgeries, that's contraindicated in those patients around those procedures, and there will be specific dosing that I would recommend either reviewing yourself or making sure that you talk to that specific provider about. So the clinical effects of warfarin, I think this is probably one of the most important slides. It takes approximately 5 to 7 days to reach steady state for warfarin, and it occurs after warfarin initiation or a dosing change. and it also takes a similar length of time for elimination of that warfarin after it's discontinued. So I think this probably is really kind of one of the most, I think, impressive parts about warfarin. A lot of times people will check an INR because they made a change yesterday and they want to see what it is today, but really you're not going to see the effects of a change, whether you're initiating it or changing a dose or holding it. If you don't change anything else and you're just changing the dose, you're really not going to see a change for probably 3 or 4 days in their INR. So it's important to remember that it does take that long to see an effect, which is why when we make dosing changes, we usually make a dosing change based on their kind of weekly average of their warfarin dose. And so we'll talk about that as well. We use the INR to monitor their effect, and factors that do affect INR are advanced age, decompensated heart failure, diet or concomitant medications, hepatic disease, and of course, patients that are non-adherent to their therapy. So warfarin dosing is very patient specific. Everybody kind of metabolizes warfarin differently, but we do have patients that are at higher risk for needing a lot of kind of dosing interventions. Patients that are a lot older, maybe at risk for falling, low body weight patients, poor nutritional status, and elevated baseline INR. So for example, patients maybe that have liver disease that already have an INR that's above 1, those would be a little bit more challenging to make sure that you're within range. And then we do have a lot of significant drug-drug interactions, which we'll talk about with warfarin. The initial dose is usually 2.5 to 10 milligrams on their first day or first few days. There is some recommendations about using specific lower doses in patients that are smaller or more elderly, and sometimes needing those larger doses if you're not seeing a response. But if you do have a pharmacy resource, this is another great place where we can help with initiating or changing doses. You'll see there to the right all the different formulations and strengths for warfarin, and I think one of the things that's really interesting that I'm not sure if you're aware of is that these colors of these different tablets actually don't change. So if a patient is always on a 2 milligram tablet, it should always be this purple color, and so it's kind of helpful for both you and the patient, as long as of course the dose isn't changing drastically, which it might initially while you're trying to get to goal INR. Really, it's a great way to kind of allow the patient to double check that they're picking up the right medication.
With our warfarin monitoring goals, we definitely want to look out for common side effects such as bleeding and bruising. Now this is going to be really bleeding and bruising out of the ordinary because patients who are on warfarin are going to be complaining a little bit more about bruising, but we do want to look out for some more of those serious bruises. Skin necrosis is also something that can happen, although this is much less common, but definitely something to look out for. With our monitoring parameters, we are looking at the INR, we want to look at the CBC, especially like the hemoglobin, hematocrit levels, and making sure they're not dropping too significantly. And then also signs and symptoms of thrombosis. Now this would typically happen if there's any kind of adherence issue with the patient taking their warfarin, but really looking for different signs of thrombosis in that regard. With our dose adjustments, we do want to adjust by 10 to 25% weekly, and then we would reassess the INR about 1 week after each dose change. So it is important that the patient does come back and recheck their INR after you make a permanent dose change to their warfarin therapy. With the INR goals, we typically see 2 to 3 for most indications. This would be like AFib, our DVT prophylaxis, VTE treatments, and then also aortic valve replacements without risk factors. So this would be different for the 2.5 to 3.5 below, where we see aortic valve replacement with risk factors. So that would be something that we want to consider for that. However, if the patient only has a valve repair, then that would still fall them into the INR 2 to 3 category. If the patient has a mechanical valve replacement, however, this would bump their INR goal up to 2.5 to 3.5 initially. And then typically with all bioprosthetic valves, the INR goal is 2 to 3.
So there are a lot of drug interactions with warfarin, as I mentioned before. I'm not going to read through all of these, but you'll note that there are medications on here that you can get over the counter, as well as a lot of different classes of medications. So amiodarone, for example, a lot of antibiotics. I tell patients that they need to be really careful, even if they go to like a minute clinic or something, that they tell them that they're on warfarin due to the potential for interactions. And then also we talk about drugs that increase bleeding risk, which you'll see at the bottom right. So when patients are taking aspirin, NSAIDs, dual antiplatelet therapy, some patients that require triple therapy, and herbal supplements, those are things that can increase patients' bleeding risk from baseline. And so those are also good counseling points about warfarin interactions. Of course, we know warfarin and food have an interaction, which a lot of patients are usually upset about, but the interaction is because of the vitamin K that's in these foods, and dark leafy green vegetables are the biggest offenders. So the collards, kale, spinach, asparagus, Brussels sprouts, those are the things that have the most green, dark green leafy in them. There are a lot of other foods that have vitamin K, but it's especially important to tell them that ideally we would like them to keep a regular diet. So often I'll say if a patient has to have, a teeny tiny, amount of kale once a week because it's their favorite food in the whole wide world and they're not going to give it up. As long as they have that same amount of kale every week and they keep it consistent, then their INR shouldn't change. But I usually try to tell them that they, at all possible, need to avoid the cooked dark leafy green vegetables because when they're cooked, they become concentrated and they don't realize how much they're eating. So if you can, give them that piece of information that we really want to get their INR into goal range to prevent them from having strokes or emboli, I think they're usually pretty agreeable. And if you can't do that, then just asking them to keep their diet as consistent.
NOAX, or non-vitamin K oral anticoagulants, also referred to as DOACs, standing for direct oral anticoagulants, have several different indications. One of these indications is non-valvular atrial fibrillation. This is defined by the American College of Cardiology as patients who do not have moderate to severe mitral stenosis or a mechanical heart valve. Should they have moderate to severe mitral stenosis or the mechanical heart valve, then the recommendation is to anticoagulate these patients using warfarin rather than a DOAC. DOACs are also used for DVT prophylaxis and VTE treatment, and some contraindications for DOACs include the valvular heart disease that I already mentioned and active bleeding.
So this slide depicts the 4 different NOACs that we have available for use. You have apixaban, edoxaban, rivaroxaban, and dabigatran. Now I will say rivaroxaban and apixaban you're probably going to see most commonly used in practice. However, I have seen all 4 used. So edoxaban and dabigatran, however, do require bridging if you're using them in VTE treatment. So a patient that has an active DVT or a pulmonary embolism, you'll have to bridge for 5 to 10 days with Lovenox or heparin, similar to what you would do for warfarin. Now for edoxaban specifically, if you're using it in atrial fibrillation, it cannot be used if the creatinine clearance is greater than 95. And this is because the body actually starts to clear the medication too quickly, and then it won't be efficacious. Pearl specifically to apixaban used in AFib, it has a special dose adjustment, and it was based on the study of which it got approved. So there are 3 different criteria that you have to look at, and if you meet 2 of them, then you use the 2.5 milligram twice a day rather than the 5 milligram twice a day. So a patient that is 80 or older or has a weight of 60 kilograms or less and or a serum creatinine of 1.5 or greater, if you meet 2 of those 3, that's when you use a lower dose. So a patient that is 83 with a serum creatinine of 2, use the 2.5 milligram twice daily if they have AFib. So that's the common mistake that is done with the dose adjustment, is they meet that criteria but they're treating PE or a DVT or using it for VTE prophylaxis. Those you do not use that dose adjustment. Those 3 are only specific to patients that have AFib and are on apixaban. Now, all 4 of them also have different renal cutoffs and renal adjustments, but in general, you will not see them used when the creatinine clearance is less than 30. though some people are starting to use apixaban more commonly in patients with end-stage renal disease or severe renal dysfunction. However, in general, you're going to see warfarin used, and it is the recommendation at this time.
Some of the pros with our DOACs, the 2018 CHEST guidelines actually do recommend DOACs over warfarin for VTE. However, if a patient does have renal disease, then warfarin or apixaban is preferred. Some benefits with DOACs: we don't have any diet restrictions. There's less monitoring that goes involved because we don't have to continue to check on the INR, but you would want to continue to check on the CBC and make sure that there aren't any severe signs of bleeding. There aren't any bridging pearls along with that as well, except with our dabigatran and edoxaban and the VTE treatment, which you saw in the slide previously. Some benefits though with warfarin, they are still preferred in severe valvular disease, and they're recommended for mechanical valves. And then it's also recommended in certain hematologic diseases. So protein CNS deficiency would be one example of some of those hematologic diseases that warfarin is still primary for. And then it is also easier to monitor in extremes of weight. So there's some question of whether or not the NOAX absorption, how it goes into the fatty tissues, whether if that's going to be an implication of that we need to increase the doses, and really how that affects patients who are morbidly obese. So more to come with that, but these are just some pearls that you can consider when prescribing a NOAC versus warfarin.
I did want to briefly touch on bridging indications. So for patients with the mechanical heart valve, atrial fibrillation, and VTE, patients are grouped into 3 different risk groups from low, moderate to high risk for their specific indication. So based on each indication and the patient's risk stratification, there are different recommendations on whether patients need to be bridged prior to a procedure using either unfractionated heparin or low molecular weight heparin. So this is a good resource if you have a patient who has an upcoming procedure and they need to temporarily stop their anticoagulation.
Here are some general bridging considerations for your reference. So typically what we'll be seeing most often is Lovenox to warfarin. So these agents actually need to be taken together for at least 5 days and then have 2 consecutive INRs that are therapeutic. When we're considering from Lovenox to a DOAC, we would usually schedule the DOAC for 0 to 2 hours before the next dose of Lovenox is due. So just make sure that we know which fits on the Q12 hour or Q24 hour dosing of Lovenox so that you're able to coordinate that appropriately. From warfarin to a DOAC, generally the protocols and stuff will say when the INR is less than 2. However, the manufacturers for rivaroxaban and digoxin have different considerations for this. So with rivaroxaban to stop warfarin and start it when the INR is less than 3, and then with the digoxin when the INR is less than 2.5. So just look at the protocols at your institution to see what they recommend. However, this is what the manufacturers recommend for each product. And then when we're switching from our DOACs to warfarin, you may need to bridge with Lovenox because DOACs have a tendency to increase the INR. So we don't have a great idea of what the patient's baseline INR is, and it could cause some confusion when we're trying to figure out what their true INR is when we're switching them over to warfarin.
There are different reversal agents available for many of our anticoagulants that can be used if a patient presents with significant bleeding while anticoagulated. So heparin's specific antidote is called protamine, and then for warfarin, vitamin K can be used by itself to restore hepatic clotting factors and achieve prolonged hemostasis, or Kcentra can be used in addition to vitamin K to achieve rapid INR normalization within minutes. Praxbind, which is a monoclonal antibody fragment, can be used to reverse dabigatran specifically. And then for our factor Xa inhibitors, apixaban, rivaroxaban, and edoxaban, we historically could only use Kcentra, which did not actually target the 3 medications, but it was our only option at the time. But now we have Andexxa, which directly binds to these medications specifically and stops their activity. So it doesn't stop the medication that's already bound to the factor Xa in the blood, but it does stop further bleeding from occurring. It's extremely expensive and somewhat restricted at this time, but you will see it be used in cases of severe bleeding. Now for all of these medications, patients can also receive transfusions to get blood back if they're bleeding as well.
This is really just an FYI. I just wanted to throw it in here as a final kind of wrap up for the direct thrombin inhibitors, because again, this is something that's very specific to being used in the hospital system. I'll just say that the bivalrudin you're more often going to see kind of in a cardiac setting, maybe it's somebody that's requiring a stent in the cath lab, and then our gatroban is what we use in patients that have developed heparin-induced thrombocytopenia. So that wraps up our conversation on anticoagulation. If you guys have any questions, please reach out before we see you in class. And otherwise, we will definitely go over a lot of this in the patient cases when we see you in a few weeks.